Hi, my name is Elizabeth Donner. I am a child neurologist in Toronto at the Hospital for Sick Children, and I also study SUDEP, or Sudden Unexpected Death in Epilepsy, and I study that specifically in children. They tend to put SUDEP at the end of the program, so I hope we have some other topics to talk about after, because it's not always the happiest topic to end on. And it's hard to be here today and talk to you all about that, because I hear from just being here and hearing your very important stories that this is a topic of great interest to the SCN8A families, and I know it's also a topic of great interest to the neurologists and the doctors that treat you. So I'm going to talk, I'm not presenting research today. I was asked to give a little bit of an update talk on SUDEP and just to share information with you. I know we haven't been having questions, but if people have questions afterwards, they can find me and I'd be happy to answer them, because I'm afraid I can't get to every single thing that might be running through people's head. So there we go. So, you know, when you look at mortality in epilepsy in general, we know that people with epilepsy are an increased risk of early death compared to the general population, and that's all people with epilepsy. Okay, so people with epilepsy are about 2 to 3 times more likely to die earlier than people without epilepsy. That's even higher for children, okay? And I'm going to get to the reasons for that. And the reasons for that are not SUDEP, they're other. So let's talk about that. So here's a very important study that was done, very powerful study. So actually, Maddox, what he did is he identified 245 children who were diagnosed with epilepsy back in 1964, and he followed them for 40 years. So we can see what happens to those people, and he's actually done a lot of work looking at all sorts of things about what happened to their epilepsy. But in this one paper, he explained what happened with regards to whether they died or not. And at 40, by the time 40 years had passed, 24% had died, and that was 3 times what you would expect from the general population. So that's about what I said, right? People with epilepsy are at about a 3 times increased risk of death in general. Now, the majority of those deaths occurred in adulthood. So this is mortality in childhood onset epilepsy, meaning epilepsy that starts during childhood, but the deaths actually occurred for the most part while they were adults, and I'll tell you a little bit more about that in a few minutes. But in general, the risk factors, so what puts a person with epilepsy more at risk to die early are having active epilepsy, which means not obtaining 5 years seizure-free, so continuing to have seizures, and having what we call symptomatic epilepsy, which is sometimes defined as epilepsy related to an underlying brain malformation or sometimes an underlying genetic malformation, so that we know the cause of your epilepsy. And another important one is this medical intractability, which is this idea that the seizures don't respond to medication, haven't stopped with medication. And finally, drug adherence, so people who don't always take the drugs as they're prescribed. So those are the things that, in general, if you take a person with epilepsy, you follow them for a long time, childhood onset epilepsy, these are the things that put you at risk for having premature death. So why would a person with epilepsy die? Well, of course, it could have nothing to do with the epilepsy at all, just like all the reasons why we all will die. Sometimes it can be related to the underlying cause of the epilepsy. Some people have seizures associated with a neurodegenerative disease or some other disorder that in and of itself is associated with premature death. And then we talk about deaths that are due to epilepsy. And among those, we talk about deaths that can be a direct consequence of a seizure. And in that, you could consider things like you have a seizure and then a drowning is associated with a seizure, or another trauma associated with a seizure. You can consider that rarely people die in status epilepticus. In fact, that's very rare in children. It's less rare in adults to die of status epilepticus, more rare in children to die of status epilepticus. And then finally, the thing I'm going to talk to you about today, which is sudden unexplained or unexpected death in epilepsy. Now, we call it sudden unexpected death in epilepsy, but I put the unexplained there because people used to call it that, and it's the same thing, so I don't want people to think it's 2 different conditions. So it's just basically the same thing. In general, sudden death is about 24 times more likely in people with epilepsy than people without epilepsy. So even if the numbers are small, it's still much more common in people with epilepsy. And I said I was going to talk a little bit in general around when children with epilepsy die, what are the causes of their death? And that's really important for us to understand so that we can kind of adjust our thinking and think realistically about who's at risk and why they're at risk. So this paper, what they did was Dr. Berg and her colleagues, they combined 4 other papers that just looked at mortality in a series of kids who had epilepsy and looked very carefully at why it was that they died and reviewed all the cases. And so when they combine them, they actually get, they were able to report on not the death of, but the lives of over 2,000 children with new onset epilepsy, followed for a total of 30,000 person years. A person year actually is worth saying is a person with epilepsy living for a year. So if I had 10 person years, I could have 10 people for 1 year, or I could have 1 person for 10 years. And that's kind of like a denominator for us to try and describe these things to people. So the take-home messages from that paper, which I think are very important, is first off, most deaths in children with epilepsy are not actually epilepsy related. So if you look at, I'm just going to pull out this, and I just want you to not, I've drawn a line through it essentially because this is that 40-year paper, and I told you most of those deaths happen in adults, right? So this isn't the one to look at when we want to know about deaths in children. So most of the deaths in children with epilepsy are not epilepsy related. Here in these 3 studies, the yellow bars were the non-epilepsy related deaths. So if they're not epilepsy related, what do they die of? Well, for the most part, they die of pneumonia. And we actually heard a very moving story right towards the end of dinner, that woman talking about her son who lived 3.5 or so years. And she did describe a boy who had developed chronic lung disease in association with multiple hospitalizations and probably lots of chest infections. And in children who have chronic neurological disorders, and here we're not talking about children who are otherwise well with seizures, but more talking about children who get recurrent infections. A way that those children most often die is from pneumonia. So pneumonia is the most common cause of non-epilepsy related death in children with epilepsy. And when we look at epilepsy related deaths, in fact, SUDEP, or sudden death in epilepsy, is the most common cause. The other ones which are less common are status epilepticus, that's in blue. And then aspiration, which is choking, right? So you don't actually necessarily get a pneumonia, but sometimes when kids are having a seizure, they can choke. And some of you are probably very familiar with that. And so rarely that's a cause of death. So just to summarize, we know that kids are at increased risk of dying if they have epilepsy. And we know that the most common non-epilepsy related reason for that is pneumonia, and the most common epilepsy related reason is SUDEP. So I just want to go back a moment and just point something out, because I realize in an effort to make this talk, which is usually an hour talk, it's more of a 20-minute talk, I've left out a slide that addresses an important point. The majority of deaths in children with epilepsy are in children who have complex neurological conditions with multiple, as doctors we use the word comorbidities, right? So a bunch of other things wrong with them, okay? So and when you think about the children who develop the frequent chest infections and frequent pneumonias, those are in fact those kids who have these very complicated conditions with lots of other problems to go with their epilepsy. And so when we see higher death rates in children with epilepsy compared to, like, let's say, adults with epilepsy, all of that increased risk, all of that increased rate of death is related to children with very complex neurological conditions. And I know that does relate to some children with SCN8A, we know that. But at the same time, we have to understand the spectrum of SCN8A likely influences the mortality risk in in those children. Okay, so I'm supposed to talk about SUDEP, so here we are. So what is SUDEP? Well, this is a table. There's a lovely paper that goes through all the definitions and how to understand it and everything. The references there at the bottom, first authored by Lena Nashef, our colleague. But really what SUDEP is when a person with epilepsy has an unexpected death and we cannot find an obvious cause. So to meet full criteria for SUDEP, we need an autopsy to be performed, and we need the autopsy not to show the cause of death, okay? We exclude cases of status epilepticus, although that can be hard to do because when we start thinking about SUDEP deaths, often they happen when people are, often the deaths are unwitnessed, so you don't really know what was happening before they died. So in fact, SUDEP, it's possible that they had a prolonged seizure, so for that reason we put in the word exclude somewhere. Documented status epilepticus, so that there was proof that there was status epilepticus, we exclude those cases. But basically, it's a sudden unexpected death in a person with epilepsy. And how common is this? Well, if you look at all people with epilepsy, adults, children, kind of severe epilepsy, more mild epilepsy, you just take every epilepsy, it's about 1 in 1,000 people per year. So 1,000 people living with epilepsy, and for over a year, 1 will die. Now, I mentioned that the severity of a child's neurological condition and the severity of their health condition influences their risk of death. That's true for SUDEP as well. So rates of SUDEP are much higher in people with drug-resistant epilepsy. So if seizures are not controlled by medication, and this is mainly adult data, but in adults with drug-resistant epilepsy, it's almost 10 times higher. So the number is more like 9 per 1,000 people per year, okay? And I realize that I've left off a decimal point here, which is kind of a bad thing to do. But the rates are 10 times lower in children than they are in the general population of people with epilepsy, so about 0.2 per 1,000, or you can think of 2 per 10,000 per year in children with epilepsy, and that's all people, all children with epilepsy, not specific to a genetic condition. Most of the time, people who die of SUDEP are found dead in bed, most often in the face-down position, or what we call the prone position, and most deaths are unwitnessed. So it depends on the series you look at. I actually reported 27 cases of SUDEP in children in the province of Ontario where I live, and we actually had a pretty high witnessed rate because I think when you look at cases in children, I think, well, I don't have to tell you that children with significant epilepsy aren't alone very often. I think their parents or other caregivers keep such a close eye on them. So for that reason, witnessed SUDEP is a little bit more common in children, but I have to say, I think that's one of the really important reasons why SUDEP is so much more rare in children, because of all the care and attention that their parents and grandparents and siblings are giving them. So that actually gets me to this statement, which is nocturnal supervision may be protective for SUDEP. So there's a little bit of data in the literature that suggests that if there's somebody who is watching you overnight, they don't have to be watching you, that may reduce risk, okay? And that data comes from, for example, a case series, so a series of patients that were reported, and this was reported some time ago, where all the young, it was kind of like teens and young adults, and they all lived in a care facility, like in a group home type setting in an institution, and all the SUDEP deaths that happened within that series actually happened when those individuals were outside of that supervised environment, okay? So not sleeping elsewhere, not sleeping within this place where there's they're in a group setting and there's someone checking on them through the night. There was also information from another series that suggested that if people either shared a room or had frequent nocturnal checks, so someone popping in on them, that also reduced risk. So people in that situation were less likely to die of SUDEP. In general, when we look at SUDEP, you know, one of the big mysteries and massive frustrations is that we all know people who have had hundreds of seizures in their lifetime and lived and not died of SUDEP. And then we know people who had hundreds, and then what happened on that one day that precipitated SUDEP. So SUDEP is not always preceded by a seizure, I should add. The definition actually makes a point of saying that you don't have to see a seizure happen before SUDEP, and that's important because it's a challenge sometimes for us to find SUDEP cases to study, and one of the misconceptions is that if they didn't have a seizure, that it was, like at the time when they died, that it wasn't SUDEP, and then we don't get to kind of collect that case for study. People call it something else. So I'll point that out for you as well. So how do we identify people who are most at risk of SUDEP? So the most important risk factor is frequent generalized tonic-clonic seizures, okay? Frequent full body shaking convulsive seizures. That is the strongest risk factor. It comes out in every study. I think we can very confidently say that's the most important risk factor. And I've written here polytherapy and putting a line through it because you know polytherapy means taking multiple drugs for your epilepsy, right? And there was an early study that actually found that being on more than one drug was a risk factor for SUDEP. Now, what they didn't do was they but they failed to control for or take into account how many seizures the person were having. So so of course, people who take more meds probably have more seizures. That's why they need to take more meds. So once you account for how many seizures people are having, it's the number of seizures that predict the SUDEP risk, not the number of drugs they're on. And there was some nice follow-up work done with that, looking very carefully at whether whether the number of drugs or any specific drug increases SUDEP risk, and they don't. Okay, so SUDEP risk, in fact, being on drugs for your epilepsy might actually reduce SUDEP risk. When they did a study looking at all the trials, all the drug trials for epilepsy, not all, but many, they looked at all the randomized controlled trials, and you know, these are the studies where they take a group of patients and like let's say half get the medicine, a new medicine, and half stay on their regular medicines. The ones who got the new medicine at a dose that was later shown to be effective for epilepsy had a lower SUDEP rate than the people who just stayed on their previous medicines. So in fact, for a very short while in our SUDEP community, people were thinking too many drugs might increase risk, but now I think it's become quite clear that too many drugs does not increase risk, and maybe even being on good drugs reduces risk, okay? So we really have to treat people with epilepsy. I know it's hard to put kids on drugs, but I'm passionate about it. Another important risk factor is nocturnal seizures. That's not really surprising when you think about so seizures that happen at night. Somebody thought when I said that meant like people who just had seizures at night. No, it's not that. It's people who have epilepsy and some of their seizures happen at night. And that kind of makes sense when you think about the circumstances in which these deaths often happen, which is from sleep in bed. So another risk factor that I want to talk to you about is this idea of duration of epilepsy. Okay, so the longer the person has had epilepsy, the higher their risk of SUDEP. And I guess that kind of makes sense, but there's something to understand there that we don't understand yet, but something to understand about the cumulative burden of epilepsy on something that we don't understand that makes SUDEP more likely to occur. So can we prevent SUDEP? You know, I told you, this is very generic advice. I told you the most important risk factor is frequent generalized tonic-clonic seizures. The thing that I think people fail to understand is that risk, when we talk about frequent generalized tonic-clonic seizures, there are people living with epilepsy, well adults living with epilepsy, going to work every day, living their lives, and maybe 8 or 10 times a year, maybe once a month, they have a generalized tonic-clonic seizure. That is considered frequent. So the risk of SUDEP is exponentially increasing with each extra generalized tonic-clonic seizure, such that even having 3 or more generalized tonic-clonic seizures a year significantly increases risk of SUDEP. So when we think about reducing seizure frequency, we really need to focus on, if you're thinking about SUDEP risk, you really need to focus on the generalized tonic-clonic seizures, so the big shaking ones, and really trying to get them right down as close to 0 as we can, okay? So that means that in general, when I, as a doctor, and my colleagues, when we talk to people about SUDEP risk, that the best way to prevent SUDEP is to reduce the number of seizures people are having. And the best ways to do that are to take the drugs that you're prescribed or whatever treatment, be it the ketogenic diet, which I have great success with as well in my center. So whether it, whether it means identifying seizure triggers and avoiding those, and this is kind of generic information that we give to, everybody. Go to your appointments with your doctor, tell them if you're having more seizures. When the story someone talked about where the drugs weren't working and then they went on the diet, it was very frustrating to wait 5 or 6 months to be put on the ketogenic diet. That idea that when drugs aren't working, we need to look for other therapies. All these things are things that we think of them as just treating epilepsy, but actually at the same time, they're reducing SUDEP risk. And so we really need to feel I feel very strongly about that. Finally, I have like a whole, Dr. Buckhalter at the back has heard me give it. I have like a whole 1-hour talk about why we need doctors and families to talk about SUDEP together and how important that is. Because if you don't know any of this, then the motivation to keep seizures under control and all that, we're not being honest about what's at stake, right? So I actually think that education of people with epilepsy, caregivers and providers, because I still go to plenty of meetings as a neurologist where the doctors that I talk to are not fully informed about SUDEP. So I think education is a very strong prevention tool. She wants to talk too. That's okay. That's okay. It's great. So I think education is really a very important tool in our armamentarium against SUDEP. As far as things that don't have as much evidence behind them, but I know people think a lot about, one is the use of seizure detection devices. Actually, just for fun, of the families, who's using some kind of device? Does that include baby monitors? What if, oh, in addition, how many are you using? Four, like every night, like all the time?
We have a tummy monitor, a baby monitor, and with camera, and a baby monitor with only noise at the back.
Okay, that's a lot of monitors. So the only monitor that I really endorse to families right now is a baby monitor, because it's the only one that I think is the least intrusive. I absolutely understand that families use other devices. I completely do. I'm not saying they don't work. I'm just saying I feel like the best thing to just recommend to most patients is to use a baby monitor so that they can hear their child if they have a seizure. But the thing about the seizure detection devices is, despite sometimes how they're portrayed maybe in advertisements and stuff, we're not going to have data to show that seizure detection devices reduce the risk of SUDEP. Some very good scientists have done the math. You'd have to give out a lot of those devices, thankfully, until you actually, you'd have to give them out to a lot of people and then wait to see if people died or not, and it's just, those are not feasible trials. So I do think that seizure detection devices, though, are going to have a place in helping people to determine, to be alerted when their loved one has a seizure. But I don't think we're going to get the data to prove that they can reduce SUDEP. I think we're going to get data that shows that they can alert us to seizures. And then I'm talking here to a group of people who have children, maybe adult children, I don't know, but who are caring for someone with SCN8A. But there's a lot of people living with epilepsy who live by themselves, and so having a seizure detection device, if you don't have anybody to answer the beep, is not helpful. But they're definitely having an increased role in how people families take care of and care for their people, their loved ones with seizures. Nighttime supervision, we talked a little bit about that. I know people ask me about the anti-suffocation pillows. I can't find any data about anti-suffocation pillows, but I know that people use them, but there's no literature to support it. I'm sure, well, it depends, but if you go and talk to your doctors about all the different things that we read about online and, you know, hear about, we often hear about things and we don't have evidence they work. It doesn't mean that they don't work, but we just don't have any way of knowing. And family education, I'd still like to find a way to prove that that works, but I think it's important even if we can't prove it. So what is being done to try and get to the bottom of this? You know, I don't know if people were you all here all day today? Yeah, because Elson So, who's the former president of AES, gave a lecture earlier today, and he talked about, actually he talked about SUDEP, and he talked about, you know, the evolution of SUDEP research and where it's going and where it was and everything. And there's been an explosion in SUDEP research, honestly, thanks in part to groups like CURE. Tracy's here today from CURE, that we're making like amazing, incredible strides. So actually, I feel like at this point, a lot is being done. And when I started studying this, my first paper in this field was 15 years ago. There was barely anything being done. So it's really a tremendous improvement in the real scientists trying to understand. You've heard some great examples today of people trying to understand what's happening with channelopathies, and that same type of work is trying to understand what's happening with SUDEP, and it makes me very excited. So I'll come back to that in a moment. I think that there's been an increasing focus on identifying who's most at risk, and not just, I told you about the clinical risk factors, but trying to actually look at some biological factors about what make people with epilepsy more or less at risk of SUDEP. And one of them, of course, has focused on the genetics. And that's one reason that people who have SCN8A in their family are worried about SUDEP, because you've heard about this channelopathy stuff, right? So, you know, Alicia Goldman and Jeff Nobles identified a mouse that had potassium mutations in a potassium channel that were present in both the heart and the brain. So the one, you know, to simplify it, the brain ones kind of give the seizures, and the heart ones increase the risk of death. And those animals did have sudden death. And now we've seen we've seen nice work presented and further more presented at this meeting around cardiac arrhythmias in mice with SCN8A. We've seen also Dr. Meisler's work, which was referred to here today, about the mouse model of SCN8A in epileptic encephalopathy having seizures and SUDEP. So this work is slowly getting to the bottom of it, and I feel very hopeful about it. And while we're talking about SCN8A and SUDEP, you know, in preparation to come here and talk to you today, I did make an effort to look and try and learn more specifically. I understand that people, I can understand why there's a feeling that people with SCN8A are more at risk for SUDEP. I can understand how we would presume that, but there's actually, and I can see why based on the mouse models. I can see why based on the fact that it's a sodium channel mutation. I can see why based on the fact that it is often associated with quite a significant or severe epilepsy. But actually, when you go digging in the literature, there's not a lot of case reporting of series of children or adults with SCN8A who have had SUDEP. And so I think the story's not told yet. I still think we don't know that much about it. I wish I had more to tell you. And I'd actually love the opportunity to talk to the families who have lost an SCN8A person, and so that we can start trying to tease it out and figure out what it is about those people that they passed, and what is it about the people who we still have with us, and how we can figure that out. So I think that would be a great opportunity, hopefully a collaboration going forward. There's also a lot of work looking at EEG markers and what EEG abnormalities may predispose people to SUDEP, and I'll just summarize that very quickly to say that there's something called postictal generalized EEG suppression, or PGES, and in studies where they've actually had people on EEG at the time that they died, which is obviously not common, but if Dr. Philippe Roulin kind of looked at cases from across the world like that, they did find an EEG pattern in the seizures of people who ended up dying of SUDEP. So there's also work to try and identify just things that might help us. We call them biomarkers, something about the person that might reflect increased risk. And of course, the strongest advantage to identifying who's most at risk would be that if we can come up with more targeted prevention strategies, like which monitors or which meds or whatever, that you could target those specifically to people who are most at risk. So this is just a summary slide to say who's the most who's most at risk of SUDEP based on what we know now, and that really is adults with early onset epilepsy and refractory generalized tonic-clonic seizures. Okay, and we do need to consider the specific epilepsy syndromes. Okay, there's more and more coming out about SCN8A mutations and where the risk might be of SUDEP in that, and now we're seeing the different mouse and rodent models of the different channelopathies, and I think that's evolving very quickly, and we're going to learn a lot more in the next few years. And just before, I want to go back to this because I want to tell you that one of the challenges in learning about SUDEP is collecting information about cases, and one of our approaches to this has been to have registries. I actually maintain a pediatric registry in Canada of all SUDEP cases in Canada. Well, I try to get as many SUDEP cases in Canada as I can identify in children. And then I also collaborate with the North American SUDEP registry, which takes adult and pediatric cases of any kind, and it's family referral. So if you know a family that lost someone to SUDEP, they can contact this North American SUDEP registry, and we can get data from the family, and that's how we learn about these cases. And the last thing is that we, it's a hard thing to talk about. I appreciate that you were brave enough to sit here and let me talk to you about it for 20 minutes or so, but there are lots of resources online, and there's just 2 places to suggest that I know have reputable resources, one of which is SUDEP Aware, which is an organization out of Canada that I helped co-found, where we have a fair bit of information online, and then epilepsy.com through the SUDEP Institute has information online as well. That's it.